Hey guys, welcome back to my channel, The ENT Resident. Today we'll be talking about tuberculosis of larynx. You can also now purchase my notes. I've added links in the description. Okay, let's get started. Now, laryngeal tuberculosis is an infection of the larynx that is occurring because of Mycobacterium tuberculosis. Now, we all know about pulmonary TB a lot. Laryngeal TB is a relatively more uncommon site of the disease compared to the lungs. And this is a disease that is more commonly seen in males. Now, moving on to the etiopathogenesis of this, most often, in about 95% cases, laryngeal TB will happen secondary to the pulmonary TB. And in very, very rare cases, in about 1 to 5% cases only, laryngeal TB would be a primary case rather than a secondary case to pulmonary TB. But this is very, very rare. And as we all know, the organism involved over here is Mycobacterium tuberculosis. Now, how does this spread occur in case of TB of larynx? First is if there is a pulmonary TB already in the patient, then it can spread via direct implantation from the infected sputum. Usually the infected sputum, it has a very high bacillary load, and this infected sputum is brought up by mucociliary clearance to the larynx from the trachea. And even when the patient is coughing, the sputum can come up from the trachea into the larynx. That is one pathway of spread. Second is it can also spread via a hematogenous or lymphatic pathway. So this is about the etiopathogenesis of laryngeal tuberculosis. Next is what are the pathological changes that we see? Now this sputum that is coming from the bronchi up the trachea to the larynx, this contains a lot of tubercle bacilli. Now these bacilli, what they end up doing is they penetrate the intact laryngeal mucosa, mainly in the interarytenoid area. I'll talk about why am I saying the interarytenoid area is the main area in a little bit. Now, once it penetrates the intact laryngeal mucosa, and this is the bronchogenic spread, it leads to the formation of submucosal tubercles. And eventually, over a long period of time, these tubercles start caseating and ulcerating. So when you look at the laryngeal mucosa, you'll see that it is very red and swollen because of all this cellular infiltration that is happening. And that leads to development of pseudoedema. There are certain appearances that you'll see when you perform a laryngoscopic examination, like you'll see pseudoedema of the epiglottis, where you see Turban epiglottis. I'll talk about all of that in just a little bit. And very rarely, there may be perichondritis or cartilage necrosis, but this is not at all common. Next is let's talk about what are the different sites involved in the larynx. Now, the most common site to be involved is the posterior part of the larynx, especially in the glottis region. Now, why is that? Why is it the posterior part of larynx and not the anterior part of larynx? That is because when you're coughing, the sputum from the lungs, it is cuffed out along the posterior wall. And there will be stasis of this sputum that has now reached the posterior wall in the all over the arytenoids in the interarytenoid region. And that is why, when I mentioned earlier that it penetrates the mucosa in the interarytenoid area, this is how it happens. This is why the posterior part of the larynx is the most common part to be involved in case of laryngeal TB. Now, amongst that, the most common sites in order of decreasing frequency is first is interarytenoid fold and the arytenoid cartilages. Then is the ventricular bands, the vocal cords, and even the epiglottis. So these are the common sites of involvement in TB of the larynx. Next, let's discuss what are the symptoms and signs of larynx. First, talking about the symptoms, your patient will usually have a history of pulmonary TB. And the earliest symptom you'll be seeing in our patient is weakness of voice. Now, this is an MCQ question that you should know. The earliest symptom in laryngeal tuberculosis is weakness of voice, and this occurs because of myositis. Other than this, we'll also see hoarse voice, dysphonia, pain on speaking, productive cough, odynophagia. Odynophagia will happen when the laryngeal inlet starts getting involved, and it will usually be to the liquids. Dysphagia, referred otalgia. Referred otalgia occurs when the tubercular lesion starts to ulcerate. Then If the lesion starts obstructing the pathway, in that case, it can lead to dyspnea and even stridor. And a typical history in tuberculosis cases is fever with chill and rigor. If perichondritis happens, now perichondritis in laryngeal TB is usually very rare, but if it does happen, the patient will also have laryngeal tenderness. Then cervical lymphadenopathy is again a typical feature of tuberculosis, hemoptysis, and weight loss. So, a significant amount of weight loss in a very short period of time will also point towards tuberculosis. So, these are all the symptoms that your patient will come to you with. Now, when we examine the patient, what is it that we'll be seeing? So, we have to perform a laryngoscopy over here to look at the larynx and determine these changes. So, the earliest sign that will happen is hyperemia of the vocal cords. Now, hyperemia of the vocal cords can either involve the whole of the vocal cords or it can just involve the posterior part only. And because of the hyperemia of vocal cords, that will lead to the impairment of adduction of the vocal cords. This will happen because of myositis. Now, this first image that we are seeing over here, the left vocal cord, you can see that there is a hyperemia of the vocal cords over here. And there's also some edema occurring over here. Next is we'll see a swelling in the interarytenoid region, giving it a very mammillated appearance. So this interarytenoid region will be swollen up, and this appearance that will happen because of it is known as the mammillated appearance. Next, we'll see ulceration of vocal cords, giving it a mouse nibbled appearance. It's almost like as if when the mouse starts biting on something, on a food material, you'll see they'll have like very irregular like lesions. You can see that in this fourth image over here, there are some irregular lesions in the interarytenoid region and the vocal cords. This irregular ulceration that is happening is termed as mouse nibbled appearance. Now, these are all MCQ points that we are learning over here. Then there will be superficial ragged ulceration on the arytenoids and in interarytenoid region, just like I showed here. Next, granulation tissue can also occur in the interarytenoid region or the vocal process of the arytenoids. Then we can also see pseudoedema of the epiglottis. Let's look at the image over here. You can see how swollen up this epiglottis is looking like. And this gives this typical appearance. You can see this is looking like a turban epiglottis. So this is again an MCQ question over here. Other than this, we can see swelling of ventricular bands, arroepiglottic folds, marked pallor of the surrounding mucosa. You can see how the rest of the mucosa feels very pale. And laryngeal mucosal inlet also becomes shallow and indolent ulcers can be seen. So these are all the signs that you'll be seeing when you perform the laryngeal examination. And the common MCQ questions over here is the earliest sign is hyperemia of vocal cords. Then we see these typical appearances like the mammillated appearance, the mouse nibbled appearance of vocal cord, turban epiglottis. These are all typical features of tuberculosis of larynx. Next, let's discuss how will we diagnose this? What are the investigations that we'll perform? Now, because this is a case of tuberculosis, you have to evaluate the chest. We'll either perform a chest X-ray or a CT of the chest and look for pulmonary tuberculosis. Sometimes even a CT scan of the neck may be required for you to assess the extent of the disease and if there is any cervical lymphadenopathy. Then we send tissue and sputum for culture for acid-fast bacilli. We'll perform Mantoux test, and then if needed, we can also do a stroboscopy to assess the extent of the disease. And lastly, the most important one, which is the gold standard investigation for diagnosis, is biopsy for histopathology. Now, when we perform biopsy, this is important because the appearance that we are seeing in case of laryngeal TB is very similar to squamous cell carcinoma of the larynx. Because the appearance is similar, sometimes you can misdiagnose it as laryngeal carcinoma instead of laryngeal TB. So it is very important that you perform a biopsy to rule out malignancy over here. Not only just rule out, but when you perform biopsy, it will also confirm your diagnosis. On histopathology, we'll be seeing granulomas which have a caseating necrotic center, Langhans type giant cells, and mycobacterium. You'll also be seeing epithelioid cells as well. So this is very, very important. You need to perform biopsy to rule out malignancy and confirm your diagnosis. Next, moving on to treatment of laryngeal TB. Primarily, the treatment involved here is medical treatment. Surgery is very, very rarely required. First of all, is if the patient is having dyspnea and stridor and you need to secure the airway, in that case, that is the first thing that we'll be doing. Sometimes you may even need to perform tracheostomy in these cases. After that, mainly it is medical treatment where we give the antitubercular therapy to the patients, and some adjunct treatment would require some voice rest, analgesics, if needed, nutritional supports. And another important point here is we will avoid the routine use of steroids in these cases unless it is indicated specifically. For example, if a patient presents to you with a significant edema of the laryngeal airway, and leading to obstruction, in that case, we will use steroids, but we will not use routinely in every case. And another important thing here is we have to remember to avoid any destructive surgery over here, because this lesions, the lesions that we see in laryngeal TB very commonly, mostly will respond to the antitubercular therapy. Therefore, we have to try medical therapy before we decide on any kind of surgery. Only in cases of very obstructive laryngeal TB, we may need to debulk the disease and do tracheostomy for the patient. So, this is mainly a medical treatment over here. Next is, what are some other differential diagnoses we should keep in mind when such a case comes to you? As I mentioned, the first differential would be a malignancy of the larynx, because the resemblance in appearance is too close. So it is important that in these cases you perform biopsy and rule out malignancy. Other differential diagnoses could be chronic laryngitis, granulomatous diseases like the sarcoidosis or histoplasmosis, some fungal infections, even syphilis. So, these are all the differential diagnoses that you should keep in mind. Lastly, what are the complications that can occur in laryngeal tuberculosis? If the treatment is not started on time, or if the patient is not responding to the treatment, it can lead to cricoarytenoid joint arthritis or fixation, laryngeal stenosis, anterior posterior commissure webs, scarring dysphonia, chondritis, or even chondronecrosis. So that's all about laryngeal tuberculosis. If you have any questions on this, please note them down in our comment section and I'll get back to you. Thank you.